Hello, everybody. Happy Thursday and welcome to the live stream. I'm David Pinkert. I'm President and Chief Commercial Officer of Hint Health. It is my pleasure to be here today to share some important information and perspective regarding the new Primary Care Enhancement Act, which was passed as part of the Trump administration's budget package, the alleged One Big Beautiful Bill. Before we get into the substance and analysis around the act, I'd like to pause and ask my co-presenter, Dr. Jeannine Rodems, to introduce herself. Dr. Rodems?
Hi, everybody. I'm Jeannine Rodems. I am a family physician practicing in Santa Cruz, California. I've been in a DPC practice we're in our 10th year right now. And I've been a member of the DPC Coalition and the California DPC Coalition now for a number of years.
Awesome. Our agenda for today is first, we're going to just take you through the substance of the Primary Care Enhancement Act. We're going to share with you some detail on the process. How did this get started? How did this get done? Including Dr. Rodems and I wandering the halls of the U.S. Capitol together in 2024 to gin up support. We're going to discuss potential impacts of new legislation, both in terms of how primary care can be financed by employers and how it could affect your practice. And assuming we manage our time well, we should have time reserved for questions and further discussion. Please remember, any questions or comments you have, please drop them into the chat. Before we get into the substance, any other opening comments or thoughts?
No, I think let's attack it. This has been an exciting year for us for DPC and finally getting this legislation through.
Great. All right. So let me give a little bit of background and take you through the major changes to policy. And prior to the passage of this act, people who were enrolled in health benefits that had health savings accounts attached to them were unable to use health savings accounts dollars for direct primary care memberships. HSAs were created in 2003 by the Medicare Modernization Act, and the original rules were written to allow people to use HSA dollars for certain healthcare expenses, but specifically not for health insurance premiums or things that look like health insurance premiums. Over the years, as direct primary care has become more prevalent, more common, it became clear that DPC membership fees, because they were typically a fixed monthly fee, could be viewed by the Internal Revenue Service as a health insurance premium. A lot of states saw that this was wrong and passed regulations which made it clear that the states did not view DPC membership fees as a health insurance premium, but the federal government failed to follow suit for many years, leaving DPC membership fees and HSAs in a state of limbo. Over the past nearly 10 years, and under the leadership of the DPC Coalition, the Primary Care Enhancement Act, which was written to fix this issue, got drafted, introduced into the House of Representatives in 2023. It took a few years of lobbying and education to get attached to the 2026 budget and finally passed this year. So what does the Primary Care Enhancement Act do? Most importantly for this audience, it clarifies the tax treatment of direct primary care and the membership fees associated with them. Specifically, the Act explicitly defines DPC membership fees as something different than health insurance premiums. This enables people who have invested in their HSAs and employers who have also invested in HSAs to use that HSA money to pay for DPC memberships. This is the most important part of the Act for you. The second part of it is that the Act also clarifies the way in which direct primary care can be paired with bronze or silver plans offered on state and federal exchanges. So those are at a high level are what the Primary Care Enhancement Act does. Dr. Rodems, can I hand off to you to share a little bit more about how this got done and some of the specific provisions which could affect scope of care?
Yes. So in this act actually was written back when there became some awareness of the fact that the legislation and the policy written for the high deductible plans and HSA plans potentially had a problem with DPC practices. So it was written back in 2013. So it has taken us these 12 years to get this through the system at the federal level. In terms of scope, actually, this doesn't necessarily limit or create a problem in terms of family medicine scope. What it's basically doing is opening access to a more advanced primary care model for patients with HSAs, where they do have not only our ability in family medicine to create, to do our work that we have been trained to do, but to provide a product for these patients that is whole person care, where there is better access, better quality, better value, relationship-based primary care that is only to their benefit, that, as you'll see, helps to reduce things like cost, provide better, healthier workforce, better productivity, and better employee satisfaction for employers who provide this benefit.
That's right. And what this, I'll get a little bit into what this means for employers. So, because of some of the work we do with the Hint Connect network, we're constantly talking with employers who are interested in adding direct primary care, but HSAs and high deductible health plans have always been an obstacle for them. The Kaiser Family Foundation estimates that as many as 50% of large employers in the U.S. offer HSA as at least one of their health insurance options. And so, if you have patients that get their insurance from a large employer, or if you're a broker or consultant working with large employers, now, virtually double the number of large employers have access to direct primary care that didn't have it before. Our expectation is that many of them will start to think about developing health benefit plans that incorporate direct primary care and maybe even integrate it with a high deductible health plan, which makes a lot of sense for us. We all believe that many of the commercial health insurance networks have substandard primary care access, substandard primary care benefits. This offers a chance to really remedy that situation so that more and more employees have access to a rich primary care network and a rich primary care benefit and experience at the same time. Dr. Rodems, can I ask you to go a little bit more into some of the behind the scenes? What happened when you were talking with legislators in Washington, and what did they need to believe to advance this?
Well, I think, first of all, when we go to Washington, I've been a member of the coalition for a number of years, and it's been these last few years that I started participating in Washington, D.C. And, it's a little scary at the beginning. You're dealing with people who've been elected, and they're in Washington, and there's sort of this, sense of, us and them. But I have to say, everybody has been gracious, accepting, interested in what we had to say. We had bipartisan support with this work, which was super encouraging. I think they understood that as a medical service, we are not insurance, and it was very sort of straightforward that many of them were very supportive. We had all throughout the last 12 years have had both sides of the aisle supporting what we were doing. So
yeah, it's unusual to have no meaningful opposition to something like this, isn't it?
Exactly. In fact, one of our original hurdles was the fact that the Congressional Budget Office had sort of spiked the bill as being super expensive. And part of that had to do with the way that they were looking at HSA tax regulations that were basically taking tax money away from the government, as opposed to the patient actually having their own pre-tax dollars for themselves. So after we clarified, that became very clear to many people that the numbers that were being proposed with that weren't correct. And I think that actually helped us in some ways to get into the HR bill with the support that we had at HR 1 in order to get this past the threshold of the Senate and in the current environment. One of the things I think that will come up is the issue over how we came up with the $150 limit. And remember, this bill was first put together in 2013, and at that time, most DPCs were well under $100 per month. So 150 was felt to be an appropriate number. We also focused DPC on being affordable, and looking for this model of care to have a broad range of patients from all socioeconomic levels. So actually in 2020, the Milliman Group did a study where they actually looked at not only how DPC was saving costs, but what the average price was at that time. And that was at $71 in 2020. So the cap needed to be put forward in the legislation so that their budget office side actually could create the numbers to give data. It wasn't going to go through if it was unlimited, but we all felt that 150 was a good price to have as only HSA dollars being used. That doesn't mean you have to set your price there, but that means that the HSA money can be capped at that with a $300 cap for families. And then it increases with cost of living expense annually once the legislation passes. So that's some of the rationale.
So just to double down on that a little bit. So the legislation doesn't restrict how much your practice can charge. It just limits how much people can pay from their HSA account. So if your individual rate is $200, people can fund 150 of that from their HSA and then $50 from anywhere else they choose to pay from. Is that right?
Correct.
That's right. I think it's important. And I think it's also important that it's inflation adjusted. So, over time, that should increase at the same rate of medical cost inflation. And so that that's not going to be a permanent feature of the act.
Correct.
Now, is there anything in the bill that limits what you can or can't provide as a DPC provider? Is there anything that would change someone's scope of practice?
I don't believe so. No, this was totally tax regulation. So the intent was taking the ACA information where we had DPC actually listed in the initial ACA bill and assigning it as a medical service. So scope of practice was not a component of the bill.
Yeah. And now, as you think about how you're preparing your practice for what changes may come, how are you thinking about that? What are the things that you feel like you need to do differently to be ready for the effects of this bill?
So I do think now that we all know that we're coming into the end of the year, the fall season, there's going to be a lot of transition that's going to occur with patients and new insurance and the Medicare side of it and all of this that we often see. This bill will go into effect on January 1st. So while people will start looking at this, I think we have to start thinking about some of the scaffolding and support that we may need, especially moving more towards an employer-based model. I personally in our model have done mostly just straight patient care. We have very little business based DPC patients. So we have done less employer, more of organic growth.
Mm-hmm.
And I think we now need to be more prepared to take on a little bit more of that employer-based growth, since we will have the 2023 estimate was 61 million people have HSAs. So the ability of having access to that population to be able to produce a DPC contract and engagement at this point is going to start to grow. So we need to be prepared for that.
Yeah, we see it similarly. As we talk to brokers, consultants, and employers about our Hint Connect direct primary care network, for the last couple of years, one of the big questions we've gotten is this compatible with HSAs? And the answer had to be not. It's not compatible. And so many of those employers and producers who had asked that question before coming back around and asking us, is now the time for us to include direct primary care as part of an employee health benefit. It's hard to know exactly when that uptick is going to happen. I don't right now think it's going to be a tidal wave of new DPC patients coming in the door, but we all need to be ready because it should be more. And this is a good outcome, we believe. And, hopefully there's enough time for all of us to make sure that we're ready for additional volume and more employer involvement in direct primary care. We've also talked with practices who are even being a little bit more aggressive about it, that, they're going to put on their websites or put in their marketing, now we accept HSA funding. And so, there are little things that you can do that might have a big impact on employers and employees and patients that are thinking about trying DPC this year.
That's correct. Yes. I mean,
Yeah.
we've all sort of tiptoed around this, and I think we all know, those of us who are in the model, that we've sort of said, ask your accountant. We have to officially say no. And we all know that this is needed some correction, especially at the employer level.
Yeah.
At the private level, I think that, patients make a decision about what card they do on the other side of whatever membership platform you're using.
Yeah.
But this will make it easier for us who do that, and then we'll expand the employer market for us as well. So,
Yeah. We got a question from Matt Dinsmore asking how Hint may help process individual HSA payments for DPC memberships with employers who want to sponsor their employees' DPC membership. So generally speaking, the HSA funds are managed either by the TPA or by an actual banking partner. And regardless of whether it's managed by the TPA or by a bank, those are funds that those are trading partners that Hint can connect to and process those payments already. So for us, it's just another trading partner. And, we don't believe we have to build any additional software or integrations to make that happen. So we believe that it's going to be relatively simple to implement on our end. And, the good news is, HSAs already exist. The banking partners and the TPAs that support those already exist. This is just one more place you can spend the money from those funds, if that makes sense. One other thing that we're paying attention to is timing. As we get into September and October, that's really the time when employers are making decisions about what health benefits we're going to offer, what network we're going to offer, what's included and what's not included. And so, this is really the time when I expect clinics are going to get questions about HSA compatibility and whether you're accepting new members. And then as we get into November and December, that's when the decisions are made. And now people are selecting their benefits for 2026. So it's interesting that this got passed recently. The timing is a little bit tight, but I think we all may be seeing lots of questions and lots of interest in the coming month or two. I'm checking our comments question to see if we have any more questions from the field. So from a policy standpoint, here are a couple of what's next. So basically what the bill has done is it's instructed the IRS to now make it legal for HSA funds to be able to be used for direct primary care. The IRS now has to write and issue those regulations by the first of the year. So the legislation's done. The regulatory part still needs to happen. So there'll be a little bit more to come when we see the final regulations issued from the IRS. Although my belief is those have been written for quite some time and just not enacted. So we'll see if there's any additional drafting that goes into that.
right. The other things that you might wonder about, and the coalition has been working on, is Medicaid and Medicare.
Yeah.
We do have another piece of legislation that we've been working on. It's called the Medicaid Primary Care Improvement Act, which is, I think it's HR 1162. And it is actually trying to help states that are interested in creating a DPC primary care platform with a wraparound product for their Medicaid population, and sort of forcing CMS to come to the table and not go through the onerous waiver process in order to create those pilot programs and start working on that type of platform. So that's one other thing that we've been doing. The Medicare side of it, we've just started preliminary discussions with CMMI, which is the Center for Medicaid and Medicare Innovation, to work on having a discussion with Medicare about considering a PMPM type of model where DPC can participate and not have to deal with a lot of the regulation and metrics and reporting and all of those things that are typically what we stepped away from in order to be a part of a DPC model. So those are some of the things in the future that the coalition is actually working on.
Yeah, that's the real challenge. I think there's a lot of buy-in at CMMI that direct primary care would be a good idea for those enrolled populations. The trick is, how do you do it in a way that you don't put so much reporting and government oversight in place that you wind up destroying the direct primary care experience?
Correct.
Yeah. We have one more question, an additional question from Melissa. Thank you, Melissa, for the question. What is the recommendation for current DPC plans that have medications bundled into monthly fees to comply for 1/1/26? I think some of that's going to depend on the final rules issued by the IRS, but I don't have a better answer than that yet. Dr. Rodems, do you have a better answer than I do for that one?
I think this applies basically to the membership fee. So I don't know how you've set up bundling medications and not keeping that accounting separate. I know some people sort of tie stuff together, but that I think still needs to be kind of clarified. I would agree.
If it's okay, we'll do a little bit of research on that, and if we come up with a better answer for you, we'll post it back to all of the attendees.
Yep.
So, we've been very busy talking with employers who have an HSA product or an HSA benefit that are interested in providing a DPC. We're kind of curious to see how quickly they're willing to move, and if now that this obstacle has been taken away, if they're really willing to jump into it. We're about to publish our current employer trends report, but I'm actually much more interested in our next employer trends report, because I feel like when we publish an update to this in a year, we will have learned a lot about how big an obstacle health savings accounts and tax treatment really was to the adoption of direct primary care. I think many of us believe it's a big deal and is going to drive a lot more demand for direct primary care services, but you never know until you're actually in the market and people are making real decisions and writing checks.
So it looks like we have one more question. About how DPC fees contribute to an HSA deductible and how insurance companies will track that. Again, as a medical expense, we are a medical service. So as they are tracking medical services, it should be similar. I know we personally print up just the monthly fees, fees by statement if that's needed for a patient, and give that to them. We don't do any coding, billing, E&M coding in our documents. So it would have to be, as a medical service from a DPC practice, a statement of the monthly fee.
Yeah, and what we've seen in the past is, the better TPAs out there have the ability to fund DPC with or without any kind of medical claim. They can create the documentation themselves, and then we'll have the ability to apply it towards the deductible. But the question is a great question, and it actually was a substantial part of the bill that we hadn't covered. The bill does allow DPC membership fees to be used towards the deductible,
Right.
Of your health insurance benefit, and that also is a very substantial and important piece. But yeah, it depends on the TPA you're working with. There are many TPAs that already have the ability to do this, document it, and have the DPC membership fee count against the deductible without creating new documentation requirements from the practices themselves. Great question.
Yeah. And we have a clarification that medications cannot be included. So prescriptions are not included.
Yeah. Now, the mechanism by which those get carved out that's what we need to give you more detail on. And I don't have the details of that yet. And I think we're waiting on the final IRS regs. All right. I don't see any more questions coming in. Let's see. If there are no more questions, we can wrap it up early and everybody gets a little bit of time back in their day. I just wanted to say thank you all for joining. I know it's a little bit of a wonky topic, but I think that the effects of this are anything but wonky. I think this really is going. It's an important piece of legislation. It's rare that we see something with such bipartisan support actually get done in Washington, and so it's exciting to be a part of it. I know, for some of us that are a little bit more policy wonky, it was very interesting to watch the Primary Care Enhancement Act, get attached to the Trump budget, get detached in the Senate version, and then get negotiated back in again. I think some of the inside baseball in this was actually kind of suspenseful and fun, and I'm just delighted that we're here to talk about a bill that's passed that's going to help grow DPC broadly in the U.S. Right now. Dr. Rodems, any final comments from you?
I would like to actually say thank you to Jay Keese, who has been
Yes.
our lobbyist, has been in charge of the DPC coalition, and has been the supporter of this movement for a couple of decades now. So congratulations to him being helpful to get this over the threshold, and all of his work that he's done for us.
That's a great call out. Jay and his team did great work for the DPC movement, and I don't think we would have gotten this done this way without him.
Right.
Well, thank you all so much for attending, and we will follow up with you on any best practices or guidance that we can get you on how to bundle or unbundle pharmacy from this in a way that's tax appropriate. And thank you all for joining.
Yes, thank you.